The recording is okay. So the major objectives was to come to an agreement, like what is the therapeutic exercise and how normal motor behavior happens and how does it help in the motor learning. And even though there are many approaches which have started emerging during those phases, but many had a common denominators, but named under different approaches. So that was one of the themes of this conference, to explore what was the common thing and how we can make sure that it is all comes under a common domain, and which can help us in reconsidering our teaching approaches and to create a design for our proper course content, and to recognize what are the barriers in communicating certain therapeutic related terminologies to a wider spectrum of public. Okay, so these were the major objectives of the first step conference. And majorly, there were a lot of confusions and dilemma around different parameters or things during those times. First is evaluating the physiological basis of our present thinking and practice. And was a patient urgency in clinics pushing us to explanation that are not scientifically backed up. So were we in a very much hurry to explain to patients that we were not able to answer them scientifically, that we gave a response which was not properly scientifically backed up. Okay, this was also kind of a dilemma that was happening during those periods. I think even now there is, I think this is presently being causing a lot of confusions as well. The third is defining our problems in terms of physiology and appropriate clinical research to narrow this gap. Another dilemma is challenge of translating the discussions obtained into classroom teaching. So these were the key points that was causing a lot of dilemma, and this conference specifically was done to address these things. One of the key papers that was published during this conference was the development of normal motor behavior. So I put in a few key points from the extracts of this. I know there is too much text into this slide, but these were the major key points that was highlighted. And make sure that this was in 1966. Okay, so much of the presentation of the step one was related to the knowledge that was available in those periods. So this was the extract that was happened during the first conference, which happened in 1966. So the first key point is physiotherapists are concerned with the restoration of motor behavior necessary for participation in all life activities. So as physiotherapists, we help in bringing up the restoration of motor behavior, and that must be one of our key areas of practice, and much more interest and exploration into specifically how a motor behavior evolves is of a prime importance for all of us, like what we are all doing now. There was a specific emphasis on specific fetal movement studies, which was done by Minkowski, Hooker, and Humphrey, were discussed during this conference, which was also in this paper, which is in the Google Drive as well. So in this fetal movement studies, there were certain key things that were discussed. One is by the 7th week of menstrual age, when the size of the embryo reaches up to 20 to 21 millimeters, there is an emergence of certain specific activities, which was again considered more of a reflex specific activity, which is a response to any cutaneous stimulations. So when cutaneous stimulations of any specific areas of the perioral area and those were stimulated, people started understanding that there were certain movements, for example, say side flexion of the neck, side flexion of the trunk started to emerge, okay, which was very as early as 7th week of menstrual age itself. So slowly what happens is we started understanding and in those periods and started terming those terminologies, terming those movements as total pattern movements, wherein because of certain cutaneous stimuluses that are being given, motor behavior that evolves holistically, so that those were considered as total pattern movements. So slowly what happens is once this total pattern movements starts to arise, slowly it starts breaking down and it becomes partial pattern movements. That was also much discussed on this particular paper. In this, I think most of the concepts what we are also knowing. So extremities movements start occurring first, especially in the proximal segments, then slowly moves on to the distal segments. So these are some of the concepts that was based on this reflex maturational theory was mostly discussed during this phase of the conference. So the other key highlight is by 17 weeks, the entire body gets stimulus sensitive, except the back and the top of the head area. So almost by 17 weeks, most of the body gets stimulus sensitive. That means they gets response to stimulus. And much of the movements that arises was based on stimulus specific was a thought during those periods. And development of reflex activity was from the caudal to rostral direction. So it starts from the center and goes to the caudal direction and goes to the rostral direction as well. So as we discussed before. The next key highlight is a specific difference in the upper extremity. So there was one specific differentiation is specifically in the upper extremity. The palmar activity precedes the arm movements. So this was one different thing. What they noticed is first they started identifying movements that started in the hand aspect, then it progressed into the proximal aspect, which is opposing to where the movement starts from the proximal and goes to the distal. Especially in the upper extremity, the baby starts moving the palmar aspect or doing a lot of grasp and release activities. Those are precursor movements for getting their proximal level of control in their movement patterns. Okay, this was one of the highlighting differences that was presented in the paper. And in the locomotion, development of locomotion, it follows the cervicocaudal rule as such, like in any of the other reports that have been reported as well. So these are the 10 key highlights that have been discussed in the development of normal motor behavior paper during the first step conference. So going forward, this is a small table that was represented. I wanted to highlight here. So because some of you may not be familiar with what was discussed during the paper is when they started analyzing and stimulated certain areas of the especially the facial areas, which was supplied by the trigeminal nerves. This reflex stimuluses started giving certain responses to them. So they started understanding that motor behavior, what is coming, is based on reflexives or certain stimuluses that evoke this reflex-related movements. So some of the things that starts even as early as 7th week of menstrual age, and as slowly as the baby or the fetus develops, there are certain movements that gets more and more wider. For example, it starts from mouth opening and goes to the eyelid area and overall facial and trunk movements as well. This is a short gist of it. Much of the other tables are given in that particular paper, which is in the Google Drive as well. Okay. And motor behavior is an expression of the functional capacity of the organism as a whole. Okay, so the motor behavior or the motor aspect, what an human or an organism is expressing out, is viewed as an holistic aspect, and it is the basic functional unit of the humans. And fetus responds based on the level of neuromuscular development that happens in them. So total patterns precedes the partial patterns, as we discussed earlier. So first the total pattern emerges, then slowly it breaks down into partial patterns. And these partial patterns are components of total patterns that gets integrated into functional sequences. So a group of partial patterns are getting used when we are doing a functional activity is what was their understanding during particular time in that first phase of the conference. So in the fetal sequences, it repeats postnatal motor behavior development. So as I told before, what the sequence of development, what happens inside the fetus as the baby is growing. Similar type of motor pattern is what happens once the baby is born as well. Okay, so like how it goes from proximal to distal, or how it goes from caudal to the rostral direction. Similar type of movement is what is happening. What has happened inside the fetus is the same type of movement what is happening after the baby is born also. This was one of the understanding during that time. So the concept of utilizing this normal motor development patterns in therapeutic approaches evolved for rehabilitation. So much of the rehabilitation approaches, what was developed during those periods, follows this reflex-based maturational understanding. Like the baby responds to certain reflexes that are being stimulated or stimulated in them. So the baby gives a specific motor response or a specific movement that are being obtained in them. So if a baby is having any type of motor related developmental issue, we tend to follow certain type of patterns that can recreate or that can able to regenerate this type of movements through specific approaches. For example, say roots approach basically works more on stimulating with specific type of icing or quick brushing, etc., to generate a specific movement that comes out of it. Okay. Sorry. So all this type of approaches, what was developed during those times, is based on an understanding that the movement that is happening inside the fetus is based on reflex specific. So what and baby can be having a difficulty to perform a specific motor behavior outside after the baby is born, we can develop it through these specific reflex related techniques or stimuluses. That was the understanding. So based on this, there were several concepts and there were a lot of papers on specific approaches. So 2 or 3 papers is what we are going to discuss it today. One paper was on Bobot concept. Okay, so I think most of you must be familiar with the Bobot concept now. So Bobot concept was also based on this reflex maturational approaches during those phases. And one of the distinguishing features, even though Bobot concept used a lot of ideologies or a lot of theories which were also being used parallelly in other treatments, one of the distinguishing feature of the Bobot concepts is that techniques is the concept of the treatment. Okay, so the concept of Bobot treatment is slightly different, and they use different kind of ideas to make sure that it is not the same thing what the other concepts are using. Okay, so to keep it short, so even though they use reflex maturational kind of understanding to help the children get better in their treatment, their way of systematically assessing them and systematically giving them specific treatments made them stand out, and it's still being followed by a certain group of practitioners as well. Okay, so the picture what I put up is, I think most of you know this, the blind man and the elephant. So whatever you see with your closed eyes and you feel that this is the rope or it is a wall or it is a fan, you tend to believe that is okay. So when you see a child and you feel that this is the problem that the child might be having, then your main focus or area of treatment will be more focused towards that than understanding other aspects of it. Okay, so how one sees a problem determines the aim of the treatment. This is one of the key highlights of the Bobot concept that was being criticized also in the paper. And there are 2 things what we need to understand. One is during the treatment process, what am I changing? And second is, why am I doing that? Okay, so these 2 things, if we get the answers for that, it could better have a good, clear concept with that. So one of the answer is, what am I changing? Is it to change? Is basically to change the certain motor problem, what the child is having, or what the child is having difficulty in doing it. Second is, why am I doing it? It is to make sure that I bring about a functional change in them. So for example, the baby is unable to do a specific function. That's what I am changing, or that's what my goal of the treatment it should be. Okay, so these 2 things should be the basis of any treatment approaches that should be there. One is, what am I changing, and for what, and for why am I changing this? Okay, so a concise of the Bobot concept is, these are the 5 specific things what it addresses. One is tone. So one of the basic things the Bobot concept addresses is they consider abnormal tone as one of the key things to be addressed, and addressing the abnormal tone can help in generating a normal development in them. That was one of their ideologies. Second is, apart from this tone, there are associated reactions that are seen in certain individuals or certain babies. Okay, those associated reactions can hamper the development. So avoiding or inhibiting these associated reactions was also one of the priorities in the Woburth concept. The third thing is loss of selective movement, loss of specific control in the movements, access and inhibition for normal development. So those also are the key points that are getting addressed in the Woburth concept. Then they also give a lot of stress on sensory and perceptual loss or sensory and perceptual development in the babies. And the overall motor development that gets retarded, that needs to be reorganized, or that needs to be redeveloped. That needs to be developed back again in the individual who has a difficulty, or the baby who has a difficulty in doing it. Okay, these are the 5 basic concepts that that is included in the Woburth treatment approaches that was discussed in the paper. I would highly recommend to go through the paper which is there. So they would give a lot of insights into specific things what is commonly prevailed in other approaches as well as in Woburth, but there are certain specific differences that is a distinguishing factor in Woburth as well. Okay. So the next paper on the first conference that was also discussed is the roots approach. Similar to the Woburth's approach, roots approach also has its origin during those periods based on the reflex maturational theory. So it considers motor and sensory behaviors are not separate. So motor behavior emerges through sensory, and a continuous motor behavior also gives certain sensory feedback, which drives the motor responses, or motor development also simultaneously happens in the baby. So associated with the normal movements, there are stimuli present prior to responses, and there are those which provide feedback during the responses. So it's always a continuous process. So between the sensory and motor, it is not considered as separate by the approach followed by Margaret Roots. So how they use specific treatments, I think most of you know by now. So there are specific stimuluses that are being given either to facilitate or inhibit a specific motor behavior. It is to facilitate certain motor behaviors which are not happening, and inhibiting certain motor behaviors which are perceived to be abnormal or not to happen. This is the basis of the Roots approach. And there are 2 primary motor functions that they focus on. One is stability and mobility. So they always start understanding that mobility is where it starts to happen, where there is shortening and elongation of the muscle fibers, giving rise to specific movements. And simultaneously, when there is a co-contraction of the muscles that's happening, giving rise to stability. And the third level, what comes after that, is mobility over the stability. Okay, so this is how the Roots approach treatment techniques or treatment principles build on. Okay, mobility, stability, and the mobility on a stable body surface. So these are basically under the understanding that certain movements that are being abnormal or that are being unable to develop in a particular baby, they use certain approaches or certain stimuluses that can help develop these kind of movements in the babies. So the final aim of the treatment is to make sure that they get a particular skilled movement. What they call it as a coordinated movement. So coordinated movement, in other words, it can be a functional movement. That is what is expected out of the child or the baby. So in short, so the Roots approach, So in short, the Roots approach, even though it was widely practiced during those phases, there was not a lot of scientific backup for the Roots approach. Okay, so the main purpose why they started doing Roots approach is to facilitate certain movement that can be evolved or emerged from doing a stimulation. But what has been observed clinically is, for example, what they thought to facilitate alpha and gamma motor neurons through the specific application of certain stimuluses, etc., is not actually clinically possible, or not much of experimental studies were done to show that the stimuluses actually gives rise to a specific muscle response or movement response. Okay, so the underlying mechanism of the working of this approach is based on on a working hypothesis what Roots and the team were doing as during were doing during those phases, and it is not actually a experimental evidence. So what the Roots approach was doing was mostly on a working hypothesis, on not directly on an experimental evidence. That was one of the key statements in that paper. As predicting the sensory stimuli to get a specific response is clearly not yet understood, because to get a specific response from a specific sensory stimuli is when we give, okay, are we getting the specific response is clearly not understood even till now. Okay, so these were certain pitfalls for the Roots approach that was being widely followed during those periods as well. Okay. And the last method which we'll be discussing today is the Phelps method. This was also based on the reflex maturational theory, similar to the Bobath and the Roots approach, where they follow a lot of treatment techniques specifically to stimulate specific movement patterns that follow the maturational theory approaches. Okay, so here a brief I'm not going to explain fully into the thing. They follow specific 15 technique methods, which includes massages, passive movements, active assisted, active resisted, in a progressive manner, finally coming into more of skill development program as the child develops better with the movements. So going more into ADL activities specific to writing, reading, dressing is the ultimate aim for this treatment to be successful at the end. So these skilled movements, what is being aimed later on, okay, is based on an assumption that skilled movements develops later, and individual movements gross movement starts developing at first. Okay, but presently we know that certain skilled movements are or can possibly develop at an earlier stage, much before the basic movements also. Okay, so these are certain traditional methods that are being followed during those periods. But even these traditional methods, as we have discussed till now, right, have a common denominator, that the understanding of the normal movement development is through reflex based, or the understanding of the normal movement, how it develops, is truly based on the neural maturation, or as the brain matures, the movements emerges. So this was the understanding during those phases that was being heavily discussed, and also there were criticisms in those papers as well. Now, from there, moving on to the step 2 or the step 2 conference, what has been happened. So I think, if I'm not wrong, it happened in 1990. So there are only a few things available in the internet on that. Vasantan sir, correct me if I'm wrong, it was the second step conference was in 1990. So where there was a lot of, hi sir.
Yes, sir, that's right.
Yes, so there was a lot of change. So 1966 to 1990, it happened after almost 25 plus years, and the jump from the first conference to the second conference was huge. And there are a lot of papers, a lot of very insightful papers on the step 2 conference, and there are only a few I have put here, and I would love to do this step 2 maybe again. So only a few things what I have highlighted in step 2, which I think is very much required for our understanding and our group. So one is, the major shift is the difference in understanding the normal motor development. Okay, so from an earlier understanding of a neural maturation model to the present understanding of the systems or the dynamic systems approach. Okay, so there are a couple of papers, if I'm not wrong, where they started understanding how a newborn develops the stepping strategies. Okay, and that gave us a lot of understanding into how a dynamic systems, or how the environment's influence on the organism, and the organism as such, how it gets adapted to the environment, plays a major role in the in the emergence of movement, rather than only considering the neural maturation that is the basics of movement development. Okay, So the dynamic systems approach was one of the key things that was discussed during the Step 2 conference. And there are very nice papers, and it's very elaborately discussed. And I would recommend you guys to please go through those papers. I think it will be shared. So there was quite a big shift that happened during this phase. And but still, people during those 1990s also were following the previous models. So other aim for the second conference was also to understand like how to give more emphasis on the dynamic systems model, and how to incorporate in the therapeutic approaches also. So the few notable papers or publication during those time were Thielen studies, Esther Thielen studies on, I think there were 3 studies specifically focusing on infants' weight gain and how it is affecting their stepping strategies. So what they identified is, so they were started to analyze different infants with different body composition or different weights, and how their stepping strategies or kicking movements were different, or how the their movements were different from the other infants. Okay, this was very nice. These 3 studies were very nice, that was done by Thielen, and it created a lot of insights into the forces that are acting on the body. So until then, there were a lot of emphasis on the brain's development into it. So later on, people started understanding the influence of the forces that is acting on our bodies, effect on the motor development that is actually happening in the baby. So this specific 3 studies created a lot of interest, and and people started doing more and more research, and understood that there is a lot of influence of different systems that is responsible for giving a particular motor development in the baby. So another key point is the behavior. What is specifically discussing is the motor behavior happens as an emergence, and it is not a specific thing that can be gotten out. Okay, so a behavior or motor behavior comes, or it emerges when it is being challenged. Okay, that's what is the underlying concept that you need to understand in dynamic motor systems theory. And there is a specific work on reorganizing from a self-organized damaged brain. So to make it more easier in understanding, let us say a baby as a baby's the brain is damaged. Okay, so the movement systems or the movement development that is happening in a baby is self-organized into its a particular pattern or a particular way, because that is being considered as the best possible solution. Okay, so in order for us to create or bring about a different motor behavior in the particular baby, we need to make sure that the movement that is expected out of the baby, okay, must be emerging when we challenge the baby. Okay, that means giving a new challenge or a different positions or different variations of movements into the baby, so that the baby starts exploring or starts identifying there are different movement possibilities in them, rather than giving a particular stimulus and getting a response from the baby in a particular sequence. Okay, so which was the traditional methods of treatment. So the motor development that happens during this the motor development discussion that happened during the second conference was more on this dynamic system approaches. Okay, so in this motor development papers, there was a lot of study that was done on animal studies, especially the chick embryos and the kittens. So I'm not explain detailedly all the study what has happened in this, but what needs to be understood is that the studies which were done in this on this animal studies, what has been done, they revealed that certain motor patterns for repetitive behaviors are established very early in their development. Okay, what does it say? What does it tell us is the specific there are motor behaviors that are specific to any repetitive movements. For example, say have repetitive movements which is involved in walking, which is a repetitive reciprocal movement. That is what we are thinking that will come in the later part of the life. Okay, it starts to exhibit even during the very early stage of development as well. Okay, which is quite contradicting to the very traditional theories of thought, understanding that repetitive movements or reciprocal repetitive movements or coordinated movements comes only during the later phase of life. Whereas these studies clearly tells us that there are very high-end or very skillful movements that can be originated or that can be developed during the early phase of life. It is not that during the later phase of life only we need to wait, or the development happens in a very sequential phase. The developments can happen in an unsequential phase also, where there are certain skill movements that can happen at a very early stage itself. And in this experimental studies, what they also found out is there are movements that's similar to an adult-like movement. So the chick embryos and the kittens that were examined started showing movements which are similar to the adult cats or the adult chicks, what they used to do. So this also tells us that even in the very early phase of life, there are certain motor aspects that can be developed, which are similar to that developed on the higher end of individual as well. Okay. And the early development of, so the ultimate understanding is coordinated movements need not be weighted or need not take time for us to work on it. So coordinated movements have the capacity to be developed early on in the life as well. So we all talk about early intervention in childhood disabilities or people who have issues with brain damage, etc. So even for people with stroke or any adult brain injuries, so the earlier we intervene, the earlier it helps us in making sure that the individuals with brain damage does not go into their self-organized state or self-organized state of unable to explore multitude of movements. Okay, so there are things which can be done. There are certain movement patterns or movement variations that can be very much trained even during the very early stages of either it can be an pediatric individual or an adult related disabilities also. Because there is even though this evidences is more focused on animal related studies, there are certain other studies which was quoted in the same paper also that very skillful movements can be obtained in the very early stage of life as well. Okay, so that's why a lot of emphasis came during this phase on early intervention for babies. So the last paper what we'll be discussing is the lifespan concept of motor development. So here also there was a lot of interaction between understanding the body composition and how specific activity level what we teach for an individual brings about an effective change in the motor behavior. Okay, so one of the things was like varying the situational demands. Okay, bringing about variations in the environment or whatever the things that are available in the environment, if we bring about a change in them, and when we practice certain therapeutic approaches on bringing about certain variations in those environment and environmental related items are, let us say for example, a simple like when you are training a child like transferring or shifting or even from sit to stand, training them on various surfaces like a hard surface or a soft surface or a surface which of different heights, or even for reaching activities, reaching out to different directions or different even the toys of different weights, toys of different colors, textures, etc. All those things challenges the baby. So these things helps the baby in getting a new form of a movement or getting them explore into new. As I told before during the beginning of this slide, so it is all about getting them to get an emergence of movement. That is what is the primary importance, what the dynamic system theory says. Okay, so with this I end the slide. I know that the step 2 I have not covered much of the studies, but I leave it open to all. There's a lot of good papers that have been discussed in step 2. and it is very elaboratively discussed on how this concept of dynamic system theory can help in better understanding about the motor development. Sorry, and how specific therapeutic approaches using this dynamic system theory can bring about an effective change in the children with neuromotor difficulties. Okay, with this I end this slide, and if you have any queries, please put up in the chat box, or you can put up at the end of the session as well. Sir?
Yeah, Joshua sir, thank you. It was really very clear, the concept of what they thought in the first part, and how it drastically changed in the second part. That was really very interesting. And I'm sorry I had actually given you very less time and I had sent you the material in the last moment, but still you had managed to prepare so much of details about it. So thank you so much, sir. The basic idea for us is to have an overview of these papers. Okay, these things have been there, these things have been evolving, and then to start picking up the more interesting papers and the more necessary papers which we are not familiar with, in order to develop much more ideas about how we can improve our clinical practice. So thank you so much for doing this really wonderful presentation.
Thank you, sir.
If we can have one or two quick points or questions, if anyone have. If not, we can start moving on to the next presentation of third and fourth step conference. Rajimam, would you like to, I think, Joshua sir, you can just stop sharing the screen. Yeah. And do you want the presentation to be run, or you can show the presentation?
Yeah. No, please run the presentation for me.
Okay. Vaishnavi, Janvi, you guys have the third step, right?
Yes, sir. Yes, sir.
Yeah, you can just roll it over and you can just think.
Okay, thank you. Thank you for your help. Good evening, all. Myself, I'm Raji here. I'm going to discuss about the step 3 and step 4 conferences in terms of physiotherapy, pediatric physiotherapy rehabilitation aspects. So from the previous presentation, very well we understood that the physiotherapist, as a physiotherapist, we were following the reflex model for a very longer time. Through that, we derived a lot of approaches and we were following in our clinical practice. Slowly, we moved from the reflex model, and dynamic system model theory has been, okay, not getting the slide.
Ma'am, just 2 minutes.
So we were understanding about the dynamic system model. Joshua sir has explained very well about that. Basically, here we need to understand in a simple word, when the motor skill is developing in a baby, earlier we were more focusing on the reflexes. But after this theory, we also understood the importance of the environmental components, how the earlier experience is important for emerging the environment. What kind of environment has been influencing the development of the skill. So the same thing for the infant and for the pediatric, like when the child is developing also, the environmental factors play important role. So that is the main understanding through the dynamic system model. That is, environment has to be considered when we are making a protocol for
just one second. Yeah, is my screen visible?
Yes, sir.
Yes, it is.
Okay, Vaishnavi, I'm sharing the screen.
Okay.
Yeah, right. You can just.
Okay, fine, thank you.
So I can just tell me when to change the screen.
Okay, sure. So at the end of the step 2, we understood step 2 conference, we understood the importance of the environment. So we started slowly incorporating the activities and about the task, about the environment also when we are giving the treatment. So there is we have done a high jump from the impairment model to the activity model. So here basically earlier we were following the traditional approaches that is mainly focusing on the impairment, and we were not including the family, or we are not worrying about the need of the activity or the interest of the patient. So we were doing all the activity, all the exercises in the closed environment, especially when we are seeing that it is mainly on the bed. So slowly we have moved that. Our treatment approaches has been moved from the bed to the outdoor. That is happening through the step 3 conference. So we are understanding that here people started focusing on more on the when they are designing the exercises, they were also understood it has to be focused, and it has to be focused on the need, or it has to be focused on the body, like what activity we want. And a lot of proactive approaches has been added here also. Next slide, please. So this is a new mantra we have derived in the 3rd step conference. This is a famous paper. Everyone will be knowing about this. So here, from our earlier approaches, we have moved towards the activity. So the activity. This is the main theme has been emphasized in the 3rd step conferences. Next slide, please. So when we are understanding about the importance of the activity, they also understood through the researchers, motor activity
Chalama?
is...
Hello.
Motor activity has been play important.
One second.
So motor activity has a role in the physical and mental health of the patient, and it also improve the cognitive performance. Through that, there is a lot of plasticity also happening in the brain structure and functional level also. So motor activity has been used in most of the activities, and it has been recorded through the research also. Can we go to the next slide? So continuation of this understanding is basically when we are going with the activity, it can also, especially in terms of cerebral palsy condition, when we are understanding this, through the activity, we can also prevent the secondary complications like any other stiffness or any other muscle weakness. When the child is practicing activity, it can be prevented also. And we also understood that this motor activity is helpful to improve the cognitive aspect and social and emotional development of the child. So again, here they are emphasizing with when the neurons get insulted through the activities, there is a lot of plasticity also it is happening, thereby neural structure and functioning can also restore. Next slide, please. So here we understood that motor activity should be given with a physical world. So a lot of treadmill studies has happened. So when they are understanding the importance of the participation, a lot of devices also has been used here. So that period, a lot of mobility devices like a wheelchair, electronic devices, all that has been introduced. Next slide, please. Okay, so we got the recommendation from this paper. Activity should be given in the natural environment, and it should be as simple as when the child is practicing at home or at the school. And there should be greater physical, like computerized devices, equipments and all, if the impairment level is more. If the severity is more, then it can also be considered. Then other thing is like the physiotherapist understood that activity-based strategies has to be given in order to get the potential effect over the recovery. So mainly we understood how we have moved from the impairment to the activity here. So this is the one of the important paper which talks about the activity. Next slide. Next, please. So once we understood our treatment, like it should be focused on the activity, then we slowly, a lot of recommendation happen, like we have moved our understanding. We need to give the treatment in a different methods, and family should be involved, and it should be practiced with activities and routine whichever child is practicing on daily basis, and it should be more meaningful for the family as well as for the child also. So when we are setting the goal, we should include family members and child, and when we are giving the exercise program, all the factors also has to be considered here. So this is the model here we are getting. Next slide, please. So here we also know that ICF model has developed. So basically here when we are designing our exercises or treatment protocol, we should not focus on the impairment, not only the body structure function as well, that is the impairment level. We also should move towards the other factors like task. It should be task specific, and we also should understood the environmental factors, personal factors, and it has to be done in the participation level also. So everyone we know this model now. So this model has been understood with the activity level, and how to deliver the services has been made here. So here they also understood in the left side when you're seeing, when you're giving the treatment, it should be family focused, and that it should be easily achieved by the child, and it should be the individualized one. and participation level has to be considered. And here, when we are including the family members, we are also getting information or input from the family, how the therapy can be changed, how the exercises can be changed. So we are getting some information about the intensity or about the contextual factors. All those information we need to derive from the family and the other environment also. So after getting this information, we need to analyze. That means both the therapist and family will be discussing about the child progress, how the activity is going on, everything they will be deciding, and they will be improving the activity, improving the treatment protocol. And it should be mainly should be done in the natural environment, either at the school or at the house. If it is given, the effect will be more. That's what the natural learning environment. Even though when we are giving the same treatment inside the hospital, we may not able to create the similar environment, like how the flooring will be there at home, the height of the chair, other small parameters cannot be controlled when we are dealing the therapy only in the hospital side. So that's what this collaborative model has been advised for us. The next slide, please. Can you go to the next slide? Okay, so here the school and home environment also has to be considered, like in case of cerebral palsy child, like how to improve the mobility, whether how many steps are there in the school, what is the height of the chair, all those parameters has to be included here. Can you go to the next slide? So we derived this recommendation from the third step conference. Activity has to be given and family also should be involved. We need to promote the participation of the child, and it also should follow the evidence-based practice. So this is the basic recommendation we got it from the step 3 conference. Can we go to the next presentation? So this finishes the step 3 conference recommendation. We are going to understand few concepts from the step 4 conference now. So here, as from the previous presentation, like by Sheikh sir, last time he gave the wonderful presentation. Through that, we got idea about the participation, like basically prevention, plasticity, participation has been focused on the 4th step conference, even with the adult as well as with the pediatric one. Can I get my slides, please? Excuse me, sir. Okay, so a lot of piece has been discussed in the 4th step conference. So this is the focus: prevention, plasticity, participation, and also about the future, like how we need to move towards the next step, like using the technology and how to improve our knowledge translation. These are all the main focus in this 4th step conference. So here a few papers are there, like focusing on this topic. Quickly, I'll just go through this. So this is one of the interesting paper. Everyone will be knowing the term stem cell therapy. So stem cell therapy is a regenerative medicine. So this basic idea is the stem cell is having a lot of potential to repair and having a lot of the regrowth capacity. So the stem cell can be utilized to cure the disease or to prevent the disease also. So here they are saying that for following years, stem cell therapy is going to be the one of the standardized medical care for many of the diseases. Here we are going to understand what is the physiotherapist's role also here. We all know about the stem cell basically. It can be taken from the placenta and it can be injected to the targeted area. Most of the time, after hearing the stem cell, we understood we will be relating with a stroke also. And here it can be focused with other conditions like spinomuscular atrophy conditions also. A lot of studies are going on. When we are using the word regenerative rehabilitation, we are combining two disciplines like about the stem cell therapy, whatever we are studying, that comes under regenerative medicine. We know about the rehabilitation. So both the combination of regenerative medicines and rehabilitation give the understanding about the regenerative rehabilitation. How can we play a role in the stem cell therapy? That's what we are going to understand now. So as you know that this stems through the regenerative medicine, we are trying to repair a disease, repair the tissues, or we are going to replace the tissues, or we can also regenerate the tissues. That's our main idea. But here, they also do a lot of studies on that. They understood that like when some kind of mechanical and electrical stimuli are given, that particular stimuli will help to give some biological changes in the tissue, surrounding the tissue. Some biological changes can happen that can be helpful for the tissue repair also. So here only we are playing a role. So this kind of therapy or whatever, like kind of stimulation, electrical stimulation when we are giving, along with that our activity-based therapy also, it will be enhancing the functional recovery. So this is the basic idea behind the rehabilitation medicine. So here what they are saying is there are two different things are there. One is the musculoskeletal and neurological regenerative rehabilitation. We very well know about the stroke conditions. So in the followed by the stroke, when the stem cell therapy is used, it has been researched that it's helpful to promote the tissue healing. The same idea they are utilizing in the musculoskeletal repairing system also. So we all know that like some tissue damage is there already. We have a replacement therapy and other techniques. But when the tissue damage is extensive, those techniques are not working out. It got a lot of failure and it's not resulting with the functional recovery. So that's the reason stem cell therapy can be utilized here. So here, what we are getting through this paper is for the coming years, this stem cell therapy is going to occupy the medicine. So we can also play a role on that one. So we need to understand more about how the stem cell therapy is helping and what kind of role we can do it. So we need to get ready to become a regenerative rehabilitation therapist. Can we go to the next slide, please? Okay, so this is again participation level. This paper is emphasizing more on how to promote the participation. We are all agreeing that participation level of treatment will improve the development and it's good for the well-being of the patient, and overall it improves the quality of life. So this we are agreeing that. So here how we understood this participation level. So as it has been mentioned by Joshua sir, systems model and dynamic system model has been like motor control theories. We derived this. Participation has to be incorporated for our therapy. So we understood this even before the step 2 conference. But still, we are not able to fully understand about the participation. We are using the term participation, but still we have a lot of queries like what is the meaning of participation and what all the factors will be influenced here, and how can we measure this one, and how can I do the participation level of intervention. So what are the supportive measures are there? So these are all we are not fully understanding. A part of that only we know that. So still now we need to understand more about this, and we need to try to get the answers for all these questions. Through that, we can improve our quality care for the patient. So here, what is our expectation from this step 4 conference is therapist has to give the activities in a set of activities in a meaningful environment. And it also like we need to understand like a client goals should be analyzed here, and how the participation is going on, like that is the participation analysis, how it is going on, what kind of parameters has to be included, how you need to add additional information in that particular task. And we also should aware of how to measure, how we are going to measure the participation. So all this we need to understand. And also from the pediatric physiotherapist, the step 3 conference is telling that it should move, like our therapy should move from the impairment model to the participation model. Fine. Now the recommendation, what they are giving us, therapy should be client-centered, and it should be following the collaborative model. Family also should be involving family and others. And we need to understand the participation through other continuous education. Even our students should be taught how to do the participation level of intervention, and they also should be involving in that. So it should be included in our curriculum also. And our research, we need to focus more on this participation level. So these are all our recommendations from this paper. So we need to promote participation here. Can we go to the next slide? Okay, so here, again, I'm going to continue with the participation only here. You're able to see full slide here. Everyone can see the full slide. Okay, fine. I guess everyone are seeing. Okay, so here we were. Okay, thank you. We were understanding the participation level from the previous paper. Here we are going to little more deeper into that, like how much, when we need to do that participation level, and what is the critical period of that. That is the main focus here. When we are designing the exercises, we should focus on these things like dosages. It's really, really important. We know that frequency, intensity, and how much time we are giving comes under this dosages. But whether we are giving the optimal dose, whether we are doing the repetition properly, whether we are doing the therapy frequently. If you are not doing that, if you're not following the particular dose or optimal recommended dose, we cannot expect the changes at the body structure or functional level or participation level. So that's what a path model for dosing has developed. We will see it little later. Probably some other time also. So the model has been created how we need to improve the dosages. Okay, now we'll move to the timing. So here, there is some critical periods are there when the injury happened. Even with the neonates or even after the stroke, there is a particular period is very important, where we can expect the peak recovery period. That is, the plasticity will be rate of changes will be very high during this period. So we need to understand that period, and we need to use that period in order to get a good changes. So meaningful changes or quality of treatment can be given when we are choosing the optimal timing. So we are going to couple the dose, like whatever dose, if you are following the optimal dose, when which part of time you need to give, like the critical period of the time you need to follow. That's what coupling time of intervention with dosage. This is very, very important. So how it is going to be related with the participation, how we are going to do that one, now we are going to see. Here, the participate, like when we are considering the intervention with a pediatric group, we can start from the infant level also, and the school age beyond that also. So there are the 3 different kind of intervention approaches has been explained here at the level of participation. That is basically when the intervention, it's really focusing with the plasticity to create changes, then participation driven intervention methods, then participation intervention methods. This is according to the age, it will be changing. According to the condition also, it will be changing. So basically here, we need to approach the baby, like once we understood that there is some kind of risk, some kind of threat, we need to approach, we need to start our therapy as early as possible. That we know. Here, the timeline has been given, the early infancy to the whole life period, it has been given. So basically, when we are targeting with the plastic changes in the brain, we need to target the baby even in the NICU itself. So early infancy life and pre-puberty life. We all know that how the musculoskeletal changes are happening. So full maturation, the pre-puberty level. So these are all critical periods for the plastic changes. If we are going for the participation-driven intervention, when we are understanding how we are going to treat the infants, how we are going to teach them reaching activity, how we are going to teach them locomotion. So reaching activity with an infant life, locomotion activity, infant, and throughout the lifespan. Imagine if it is a CP kid, so you need to start therapy with the infant level, and you need to find some additional information when the child is growing. So throughout the lifespan, we need to target. And participation intervention, here mainly we can go with the early period also, school going child also, and other age group also. So this is the optimal timing. Now we will move to the next idea. What is the recommendation, or what is the need? What are all the priorities for research in terms of this understanding? Like coupling time of intervention with the dose. So there are a few areas are there where we can focus. So probably when the new research, when the students are doing, they can also focus on this area. So one is about the dosing participation intervention. So basically, when we are talking about the participation and all, we don't know what is the baseline of that. So what is the baseline, like how much time the child should be participating, how many times child should be participating, or how much time the baby should be interacting with the family and other people. So that is the normative values are not there. So slowly we need to develop that one about the participation, so that the dosing can be improved. So we need the normative values. Then high intensity of participation. So whether the high intensity will be improving their participation level, or how much it will be influencing the pediatric rehabilitation. So we know that a lot of sophisticated technologies are there, VR and other things are there. So if you're using that, whether the participation level is going to be increased, we need to understand that. And we need to understand the other aspect, like if you're changing the environment, whether it will be promoting our participation, we need to address this question. And if we are increasing the frequency of exercises in a week time, whether it is going to influence the participation level. So all this has to be addressed through our research. And we also should understand what is the threshold level to improve the to improve the quality of life. Then we also should know that, or we also should focus our research on optimizing the dosing given through the genotype. So now a lot of studies are happening in the CP. Is there any genetic changes are there? What kind of changes are there in the genotype? All those information they are trying to extract. So we also should understand along with this line whether we need to change the environment, or how much participation has to be given in this particular genotype patients, all that. So slowly we need to focus our research on this aspect also. Then the next level is in case of very severe motor impairment level, how are we going to improve the participation level? That also we need to understand, like we need to focus our research. And the last one is about the adult outcomes. So we are all, most of the time we'll be talking about the treatment care with the CP kid, CP child, but we're not focusing more on the adult CP, how we need to work on that. So how to prevent, or how to prevent the complications, or how to improve the participation in the adult life also we need to focus. So these are all the research priorities for us. Okay. So this is about the timing and the dosages. Can you go to the next slide, please? Okay, so this is the path model for dosing. We are not going to discuss now here, but basically we need to understand here, like when we are determining the dosages, we also should consider all other characters, how much it is influencing, all that we need to understand. Can you go to the next slide? Okay, so topics are going on a little bit high, but I think this paper is very much related to us. Already we are doing part of this, we are doing already. So it will be little interesting to hear also. So this is about the knowledge translation. So knowledge transition. So here, we are talking more about the evidence and other aspects, but whether knowledge transition is happening fully or not, that is really a big question. Most of the time it is not happening, we can say that. So quickly I'll just go to this understanding only, I'm not going about the detail of this. So when you're seeing the picture on the left side, it's according to the Institute of Medicine. This is the model we are just now following. That is through the research, through the science, we are deriving some idea and we are trying to implement when we are giving the care to the patient. But most of the time, it's we are not utilizing fully that whatever we derived through the research, that is not going to the patient. That is the main worry here. So through many factors it is happening. So that explain on the left side. That is basically here we are most of the time we are following this is the linear model. We are following that one. So this paper is giving the recommendation, instead of following this linear model, go to the cyclic model. So here already, I think when I was joining for the today's meeting, Subramanian sir was talking about this. So here, like we will start from the evidence-based, that is in the upper part. So we know that evidence-based practice is there. So how we are doing that, like some guidance based on that, some guidance has been derived. For example, guidelines for treating stroke, that is there. But after deriving the guidelines, that cannot be directly used to treat our patients because of many reasons. Like, for example, in the context of the regional and other factors, we may not able to fully derived the idea through the guidelines. So what we need to do is, we need to do some changes, like a clinician should do some changes in the guidance after understanding the guidance. For example, according to the Indian situation, we need to change our toilet training activities. So we need to do some small changes in the guidance, and it has to be approved. Then we need to practice that one. So that after that, we need to get some, again, we need to start do the researching. So we need to get some data. Through that data, we need to improvise, and we need to analyze that, and we need to improvise the guidance. So here, one of the major difference between the linear model and this model is, when you are doing this activity, like following the guidance and adapting the guidelines and all, we need to include the stakeholders, like clinician and family members, patient, all other people, whoever is involving with the treatment care should be taken care, and we need to get their ideas also. So through that, we can improvise to the overall treatment techniques. So that's what this model is explaining to us. So that's what basically ICF, we need to understand the other factors also here. Okay, so we will go to the barriers of this one directly here. Why this knowledge transition is not happening so easily. So as we all know that most of the time we were not able to get all the recommendation, all the guidance. So there is a limited access will be there. Sometimes lack of understanding of the papers also. Then many of the time we will be saying we don't have time. So we are not using, or we are not spending our time. So there is a time limitation to find and evaluate the appropriate articles. So these are all the main barriers. So if you are doing this, we are not providing the optimal treatment. So we cannot expect the good recovery or good plastic changes. So this is one of the things we need to understand. We need to update ourselves through the process. And we also, when you're seeing the right side, you can also understand what is the expectation as a physiotherapist. So the clinician should the clinician should play a different role. So they should understand they should be a research consumer. That means they need to read the articles, they need to discuss. So they should be a consumer. Then they also should act as an evaluator, and they should also do the researching job and dissemination. So these are all, dissemination means basically whatever knowledge you are having, you need to spread through the different aspect, like awareness program and other activity you need to continuously involve, or you can write an abstract. All this you need to play a role in order to improve the knowledge transition. So it's really important. Whatever the research is saying, it has to go to the patient. So we are responsible for that. So we need to do that one now. Can you go to the next slide, please? So this shortly, we will be discussing this. Everyone knows about the virtual reality, how we are using that in our rehabilitation. So this paper is saying that how we can use this for our peace, prevention, participation, and plastic changes. So here I'll directly go to the how the rehabilitation, VR is related with the 3 Ps. We will go and see that, like basically a prevention, how VR can be, play a role on prevention. So a lot of studies are there with both the pediatric as well as for the adult also. For example, when the obesity comes, so it can be used as a prevention. And in case of Parkinson's condition, VR can be used to reduce the secondary complications like balance issues or falls. Then participation, when the meaningful activities are practicing through the VR, we are trying to improve the participation level, even though it is near to the natural environment, but we can expect it's a meaningful, because it's a meaningful activity. So it can produce some plastic changes also. So VR is related with all 3 Ps. Now, here we will need to understand one thing. Even though we are talking more about the technology, still we are not able to use this, or we are not fully understanding about the VR. So we need to try to understand more about VR, and we need to try to utilize those technology, and we need to try to fill the gap, do a lot of studies on this. Lot of resources, online resources are also available now. So we need to focus with a VR, how the participation level can be improved, what kind of outcomes we can give, and what even the physiotherapist can give some input when we can give the VR therapy, how it can induce plastic changes in the brain. So these are all the focus and recommendation we can work with the VR. So let us know more about the virtual reality. Let us use a lot of resources also, it is available. Let us use that one, gain some more knowledge through that. Can we go to the next slide, please? So these are all the 4th step conferences ideas or recommendation. So let us move more with this recommendation to improve our patient life. Thank you. Thank you for listening.
Yeah, thank you so much. I think we had a lot of refinements when we had moved on to the 4th step conference, and a lot of nuances in the application of the ideas of the 3rd step conference. And it was an eye-opener, and thanks for the beautiful slide structure which you had given it. I think if we can share it across, it will be helpful for people to read it also. So thank you for it. We'll have quick questions. If questions or anything needs to be told, you can please tell it. We'll just say 1 or 2 minutes and then move ahead.
Ma'am, that was a nice presentation, ma'am. I'm having one doubt. Since we are dealing with adult patients with stroke, we are not much exposed to pediatric population. So I am not exposed much to pediatric population. So I want to know when we are doing our undergraduation, we used to go to Spastic Society in Chennai, and we used to see the sensory integration for. Hello.
Okay. Yeah. Sorry. Yeah.
Yeah, we used to see there is a separate sensory integration room, and they used to train the children in that room for ADHD autism patients. So what is the evidence for, as we have discussed in the pre-conference, we have to move on to the evidence-based practice, and we have to move on to the activity level and participation level. So what is the current practice on this ADHD and this autism type of patients? Whether
I'll share.
Task-specific training is having the much evidence, or sensory integration still they are applying and it is benefiting more than task-specific training. So can you little show light on these things?
Definitely. I'll try to explain. If needed, I'll ask help from Joshua sir also. Basically, we all know that we need to see the child as a whole. We should not separate the different aspect. Like when you are understanding the whole behavior, so we need to treat the whole behavior only, but still everywhere the sensory integration by the occupational therapist are still it is happening. Currently, I'm not practicing with that kind of population. So, but our OT therapist, they are practicing that only. So if Joshua sir is able to add few more points, please, sir.
Yes, ma'am. Sir, actually, right now, what they are mostly doing for children with autism is they call something like ABA. So, behavioral therapy approaches are being put forwarded for people with autism, and that has been showing a lot of good improvements in them. So, applied behavioral analysis or is the present sort of treatment what they are what is being scientifically proven for them, and a lot of psychologists and behavioral therapists, they are into this practice with for children with autism. But there are certain places where they do a combination of both. For example, say sensory related therapies and also ABA. But I think standalone ABA has a lot of good benefits for children with autism and ADHD.
Okay, sir.
Okay.
Okay, I think today was a very calm presentation as compared to last time we had 4 speakers and we all were rushing up in order to explain that. So today we had more clarity in the pace of the presentation. So thanks for it. Of course, we'll continue reading these papers and seeing it. And the most important thing is we wanted all the audience to start look at the papers and start reading them so that you can know, you can keep pace with that. Okay, right? So just I will take 5 or 10 minutes to present our website. It's been a long time that we have been doing a lot of activities. So we thought that if we can put it across together, it would be a good enough resource for us. So I'll just share my screen now. Are you able to see this?
Yes, sir.
Yeah. So as a group, we had done a lot of things. And so I thought it would be very beneficial if we have a site which can explain what works we have been doing, and it will also serve as a resource. Here we have a few buttons. This is the home button. It has majorly the events which we had conducted in the past, and also what are the events we are going to conduct further on. The details will be given here. And also you can see most of your names will be there. We are the group, we all have joined together and then, so I've kept all your names there. This page is a landing page. So you can see here, there might be a small lag, but this is click here for upcoming events 2023. Can just click here and it can go. And past events, we have been very actively listening to many of the lectures. So what are the past events has been there? Calendar is also available, which talks about what we are currently doing. So you can, time you can see the calendar, so you can know what are the further events which are coming down. Okay, right? These are some of the international events we have attended, and I've just kept a group activity report. It might not be visible at the current point of time, but I'll send you the link so that you can see this. So what are the activities we have done in the past 4 or 5 years as a group is available here. Okay, right? Then, yeah, so this is an interesting page. Because it's taking, I think since we are in the Zoom, it's taking some time to upload. So we have the Oxford group, the I think someone's speaker is on, and I think they are dosing. That's fine. It's normal. So I have kept all your names, so you can just go through it. Just one. Next is the panel on motor control. So what I have done in this particular panel is try to capture all the last century, that is last 100 years, what has happened in the field of physiotherapy, specifically with neuro. So it has, you can see here, there are multiple pages. You can go through each of the pages. It starts from physical exercises before 1900s. And then Sherrington has come on the scene and we had the reflex model. So I've kept all the reflex model presentations, what our students have done and we have done in the past over there. And then what are the treatments that's based on reflex model. Then we move to the second part of the 20th century, that is 1950s onwards. We have the motor program model. So we had done a lot of presentations in motor program model. Primarily, you will have in these pages videos as well as papers as well as books to read on in this, right? So this one. And then the current 2000 to 2020, the reference configuration model, what we discussed in the last year. Also, I have kept the recent papers that we have, when we attended the motor control summer school, each of us presented 1 or 2 papers. So all the paper, the recordings are there. And then lastly, the current scientists like Latash, Anatole Feldman, and others have kept links to the scientist speeches. So it's predominantly video. So it will, I think it will might be easy for you to just go through it. Right. So I'll just try and go to one page if it's uploading. So it's fine. Okay, so I think it's taking time for the video to upload, but when you see it will be more faster. Okay, right? These are the videos which we have discussed in the previous one, the motor program model. What are the problems in the motor program model and what are the solutions? Okay. So that's an example of the paper. Then we have the next part, which is behavior change. And what I've done, and this is, I've just tried to keep what are the current behavior change model which is there. And just give me a second. Yeah, this is in the last year we had started discussing about behavior change. So the presentations and the corresponding reading materials for that is also provided here along with the reference book. So you can get the reference book. Of course, we do have all these resources. So anyone is interested, you can always get it. So the name suggests I had primarily developed these two pages, one on motor control and one on behavior change. And behavior change also has a page on a human behavior change project, which is currently we are attending on every Wednesdays. So the registration link is there. So if anyone has not yet registered, you can please go ahead and register with that. Okay, right? Then I have two more pages. One is on recent advances. So here I have kept primarily two pages. One is what are all the journals on motor control and behavior which are being currently, which are published. Okay. Just it will take some time to load. So I've captured the major journals which publish on motor control and the corresponding links. So you click on it, you'll be automatically taken to the page. Okay, right? And what I have done is in each of these pages, we have what is the latest publication which is there. I've given a link to it. So you click onto it or automatically go to the current month or the previous month, what latest issue available that you'll be able to access from here. Okay. That's about journal on motor control and behavior. And then also there is a page on societies related to motor control and behavior. Today morning, the earlier part, Silva sir was telling if we can become a chapter of a international society or something. So I have captured many of the societies which are related to motor control. For example, GATE and Clinical Movement Analysis Society, European Society for Movement Analysis in Adults and Children, Force and Motion Foundation. So these are some of the societies which we found interesting, and I have kept it here. And also in the end of the page, we have the conferences which are going to happen and which are recently happened. So in 2023, right from March onwards, what are the conferences which are majorly happening? The link has been provided here. Also, if anyone wants to participate in the conference, the submission deadline for the abstracts will be uploaded here. So you can look into it. And if you are interested in participating or presenting your work in the conference, you can always click on the link and go and submit your abstracts and then go about it. Okay, right? So the last part of the recent advances file contains a review of some of the books on motor control. For example, just try keeping a review of Shamwe cookbook, a summary of it, the latest edition of it, what are the chapters and what do they basically talk about. This is going to be a page which is going to advance. That is, we will be adding more resources to it. The last page, we have the resources, that is books, number one, which are available. We have collected more than 150 books on motor control, and it starts from 15th century, 15th century onwards, that is 1473, book by Leonardo da Vinci on motor control. From then on, 15th century books. Then we have 18th century, 19th century, up until 2022. So I know it's a huge chunk of material to read, but we might be able to master one or the other day. We might be able to cross this barrier of reading and understanding all the books on motor control, so that we can keep inventing and we can keep going. And yeah, that's the major chunk of the website. Now this website, I'll send you the link in our group. You can also look into it. It's just the beginning. There are more things that we can add, and I want all of you to get actively involved in building the resources. The recent advance especially is something where we all need to join together and then read some of the journal articles, and then place the summary over here, so it is easy for all the others to go ahead across. Okay, right? So that is in brief about the website. I hope it will be helpful to all of us. And I'm also sorry that I have put all your presentations without asking you. And I hope you wouldn't mind it, because basically we have been a very democratic group. So I think we'll be going through. So please do go ahead and see the website. And if you have any suggestions or things, you can always suggest it. Okay, right? So with this, I'll stop sharing.
Sir, fantastic effort. I think that this is some thing to start with what all we are discussing in the beginning.
Yeah.
So this will be a leading point from there.
Yes. Yeah. My only aim was to see to that we had put in a lot of effort, all of us. We had a lot of hours we have spent. The best part is luckily we have recorded it, right? So we don't keep repeating it, and all the newcomers who are there who want to learn more, they can always join and do it. Okay, right? So that's
why the recordings were happening.
Yes.
Okay. Great.
Wonderful work, Sundram. Very excellent work. You've taken a lot of pain and effort to construct this.
Just the summary part of it, right? All of us have worked, right? So it's dedicated to every one of us.
Thank you.
No.
Thank you. And all presentations were very excellent today. And thank you very much.
Okay, sir. Yeah. So I'll send the link. Please do go ahead with that. Okay, right? And thanks to everyone for being awake, skipping your dinner and things. So yearly